Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome everybody again to another episode of our show, bringing you another fascinating guest today involved in creating a better tomorrow. Today we have the honor of being joined by Dr. Anders Nordström, who is Ambassador for Global Health at the Ministry of Foreign Affairs of Sweden, member of the Virchow Foundation for Global Health Council, as well as Secretary of the Independent Panel for Pandemic Preparedness and Response, was recently established by the World Health Organization, ultimately tasked with evaluating the world's response to the COVID-19 pandemic. A trained physician at the Karolinska Institute in the field of both national and international health policy, planning, and strategic leadership. Dr. Nordström has held the position of Ambassador for Global Health at the Ministry since back in September 2010. He's also served as Assistant Director General and Acting Director General for the WHO. He was also head of the WHO Country Office back in Sierra Leone. Additionally, he's a member of the Commission for Universal Health, convened at Chatham House. Previously, Dr. Nordström held several other important roles, including CEO of SIDA, the Swiss International Development Cooperation Agency, worked at the Global Fund to fight AIDS, tuberculosis, and malaria in Geneva for the Red Cross, and he's been posted internationally in a diverse range of countries from Zambia to Cambodia to Iran. A lot of really important topics related to health to get into today. Ambassador Dr. Anders Nordström, thank you so much for taking the time to come on the show today.
No, thank you. Delighted to be with you. I mean, just listening to you, I'm just a bit amazed and surprised that I also have a family. Actually, it's not only been work during the last 30 years. I'm very honored and pleased to be able to have a great family as well. So I've done a lot. I've had the privilege to do a lot, but also I spend time outside work as well. Even
Absolutely.
if just listening to you, one would not believe that or think so.
Absolutely. No, I totally understand that. I appreciate you sharing that as well, Matthew. Anders, you've been on this quite an amazing journey the last few decades. I'd just love to start off, at the beginning. If you could take us back a little bit, sort of, I know you're trained as a physician at Karolinska. Why global health? Why health policy? And I really enjoyed, looking at a bunch of your articles in the peer-reviewed literature, and one that stood out quite early on was your 2004 Lancet article entitled "Responding to the Global Human Resource Crisis." And in this, I think, sort of sets the stage for a lot of this theme and a lot of your work about doing a little better. That in this particular case, we can put all the money we want into public health systems, but if we're not thinking about people and supporting them in those systems, we don't go very far. Take us back to those early days, if you would.
No, thank you. I mean, going back to the early days, as I said, I was trained as a medical doctor at the Karolinska. This is now more than 30, almost 35 years ago. And already as a student, I wanted to engage in something slightly more than just sort of working in Sweden. I had a friend or sort of more of a role model that I was following, who was a surgeon, and I wanted to become a surgeon as well. He had been working across the world and been in Cambodia, been in some of the most difficult emergency situations, and I was quite tempted and intrigued by this and seeing that you can actually make a real difference to people. So that was basically why I became a doctor, and I wanted to become a surgeon. But then during my study at the Karolinska, we were a group of students engaging and seeing, okay, how can we do something more again than what we're doing in Sweden? And we got engaged in a project in Sierra Leone for children having diarrheal diseases in the mid-80s. And we set up a project for young doctors there. I never worked there, but I started the project. Then I sort of continued to be engaged. Then I had the possibility to get my first job assignment abroad in Cambodia for the Swedish Red Cross. That's the only time I worked as a real doctor. And then it was just a coincidence when I came back there. And also then I had done an assignment for the International Red Cross Committee in Iran during the first Gulf War. I still wanted to continue as a clinical doctor, but then the job situation in Sweden was a bit difficult. I met my wife. We didn't want to move from Stockholm. And just by sort of coincidence, I ended up at Swedish SIDA. And then at Swedish SIDA, I directly went in sort of into more of health policy. And I became responsible at that unit for our engagement with WHO. This is now 32 years ago. I went to my first World Health Assembly, and then it just continued. So I've had the privilege of doing a lot. I've basically never applied for a job. It's only been sort of one thing coming after the other. I've had the pleasure of making this journey.
Excellent. And, the theme of health diplomacy, of scientific diplomacy has come up, on our show. We've had folks on like Dr. Kengasong here at running PEPFAR and Ambassador Rontigan in Norway. You, however, I think you're the first of this interesting breed. You were, it was back in the early 2010s, the Minister of International Development Cooperation, Gunilla Carlson, appoints you technically the world's first global health ambassador. You actually write a very interesting paper at the time in the Lancet on global health engagement, how it could be better. Talking about, we have the Global Fund, we have Gavi, we have UN AIDS chugging along, but so again, this theme of needing to do a little better. Talk about what was happening then. You talk about the stars aligning at that time, the role of a health ambassador. What was very unique at that point? Take us into that period, if you would.
Now, it was an interesting period because before that, there had been a group of global HIV/AIDS ambassadors. So, like, for instance, John's predecessor, who was the head of PEPFAR at that time, he was also the ambassador for HIV/AIDS. There was a person here before me in the Swedish Ministry. But at that time, also, the HIV/AIDS challenge was still very much there, but it was more than that. So the Swedish government then decided, when I got into this job, to, after just a month, to change the title, also to send a signal to say that the Swedish government's engagement is more than HIV/AIDS. It's actually health, and it's global health, and recognizing that a lot of progress on the ground in very many countries, but we still have important work to do together on health at the global level. And this was, as you remember, still during the MDG era in 2010. So also sort of seeing how we can contribute then to that sort of bigger picture. What I've learned then, and what I'm very much engaged in today, during those 13 years I've been in this position, is that politics matters a lot. It's not just about having the medical or the public health evidence in terms of what needs to be done and the rationale to say that, yes, we see now that we have big issues on TB or on HIV, AIDS, or on cancers today, but you need to understand the political dynamic. There is a rationale to politics and why political decisions are taken. When, for instance, Dr. Brundtland, the previous Norwegian Prime Minister and Director General of WHO, she was the first person to be able to attend a G7 meeting. This was in Okinawa in year 2000. And how did that happen? That she had access to that room. And this was the beginning then of the establishment of the Global Fund. So understanding the politics, how do you actually enable politicians to be able to make decisions that makes a difference to people's health? That is something that has interested me a lot. And this you can call global health diplomacy, or you can call it political economy, but basically saying that it's not enough to know only what to do, but you need also to have the knowledge and interest for how to make it happen, the how questions. So I'm actually going to leave my role here in the ministry now during the fall. And one of my priorities and plans now for the continuation is to set up a program then for global health diplomacy and international politics with the Stockholm School of Economics and the Karolinska Institute, to enable people slightly younger than me to have the possibility to learn in terms of the practical skills and the tips and the ideas in terms of how can you navigate in a political landscape and be successful. And looking back historically, there are many good or bad examples as well, where we have been successful and where we have failed. But having a bit more of understanding in terms of the politics, I think is extremely important. And I've never been a politician, but I've always enjoyed working with politicians and also understanding politics and of course also respecting politics.
And you know, speaking of, you know, successes and failures, I mean, you've had some major, and you've talked about emergency situations. I mentioned, you know, you were in Sierra Leone, you were sort of in the mix as Ebola was happening back in sort of the mid 2010s. I think, you know, from someone sitting on the United States East Coast, that looked like a major success story. You've also, you know, you've written in the PLS Medicine 2016 in March, and you know, you wrote this piece on and speaking of politics and major sort of issues that are still out there. You wrote this article on translational research with tuberculosis elimination, talking about sort of the WHO strategy at the time. You know, TB is one of those ones that bothers me a bit. That, you know, being sort of familiar with the area, you know, we got this vaccine that's over 100 years old and anti-tubercular agents that are, you know, from the 1940s. Compare and contrast those two situations for us, if you would, because you've been in the thick of both of them. One we've done extremely well at, one it's taken some time to move the needle on. Take us into that era.
It depends a little bit what you compare with, but if you go back to the early 20th sort of, and the three diseases, the AIDS, TB, and malaria, when again I was mentioning Dr. Brundtland, that was really the beginning of the Global Fund. I was the interim executive director making the Global Fund up and running in the year 2002. The momentum we had at that time for the three diseases were enormous. What we see today, we have a much more complex political situation when it comes to dealing with now the lessons from the COVID-19 pandemic and how to create an international system that will make it more safe for the future. So in some way, if you look at TB, if you begin to look at TB in relation to HIV and malaria and malaria, I think we made more progress on HIV, even if we still do not have a vaccine, but we have been quite successful in terms of both getting people on treatment, less people actually, of course, dying. We have been able to reduce the number of newly infected people with TB, and we have not been so successful perhaps on reducing stigma and respecting of human rights, but still some progress. Malaria now, I'm quite optimistic now with the new vaccine coming. We see areas that have been, where malaria now has been totally eliminated. TB, as you say, I'm not a TB expert. I think you interviewed previously Eric Gosby, also one of the heads of PEPFAR, and Eric is really a lead on TB. But my take on this is that this is much more of a neglected disease in some way. It's never been really the big investments in the research. It's never been as attractive as HIV/AIDS, and you haven't got the same community. So we are not making the headways. And on the contrary, what is working against us is that resistance against the TB drugs is increasing. So we've seen much more of multi-resistant drugs, multi-drug resistance for TB. We do not see any major progress on the vaccine side. Hopefully now that, I mean, that could be something that comes out of now the COVID-19 pandemic, even if that technology will not be able to use that for a TB vaccine. But still, I think what we have with us now from the COVID-19 pandemic is that it's possible. It's possible to do something big and difficult in a very short time period. So the big success we had now with the COVID-19 vaccines might also trigger us. But the risk with TB is that this is a little bit of a forgotten disease. This is mainly done for poor people. This is not really what is on top of on the political agenda. So TB is a concern if you look at what's happening globally.
Speaking of COVID and COVID lessons, you've, as I mentioned in the bio, you're part of the independent panel for pandemic preparedness and response. You've, in the last couple of years, written quite a few papers on resilience, health system resilience, resilience per misinformation, the fact that we got a digital pandemic here as well. Take us, talk a little bit about the panel, if you would, and a little bit, if we could focus on the your one paper, Health Systems Resilience in Managing COVID-19, Lessons from 28 Countries, because you really distilled down, what we got right, what we didn't get right, and, our learnings for, God forbid, COVID-3.
No, that was a huge privilege to work with two fantastic leaders. Former President Ellen Sirleaf Johnson from Liberia and former Prime Minister Helen Clark from New Zealand. And it was very brave, I think, of also the Director General of WHO, Dr. Tedros, then basically to ask those two leaders and to give them full independence to set up a panel and to select and to recruit a secretariat. So they asked me to become the head of the secretariat. And we then selected 11 panelists, really top-notch people from across the world, both people that have been working and done the work in real life, like the former Secretary of Health from India. We had, but also political leaders like the former Minister of Foreign Affairs from the UK, David Miliband. We had the former Minister of Finance from Colombia, Mauricio Cardenas. We had the head of MSF, former President Joanne Liu. So really top-notch group of people. And then we were giving the task then basically look at the big picture. What has happened now? This was then only, when we started, it was only 9 months into the pandemic. And then when we delivered our report, it was sort of after 1 year, 3 months. So it was still at the very early days, but we had quite good resources to basically to do three things. We look back to see what we can learn from the past, what had been in place before everything sort of started, what happened at the initial phase, and then looking at how health systems coped, and also how the international response looked like in terms of international organizations respond. And we did a report, we did 16 background papers. There's quite a lot of material there, especially for future people that will have an interest in research. But the big picture lessons were that the world was not prepared. There has been a number of warnings, basically previous reports, commissions saying the world is at risk. This will happen again, but no action had been taken. And the second problem was, when we look back, was that we have had systems or tools and ways of measuring to see whether countries were ready and prepared. We had something called the Global Security Index, and we had what WHO is organizing and managing the so-called joint external evaluations. And the countries that ranked highest, being best prepared, that was the US, and some other countries that did actually not do so well. Some of the other countries that actually did some quite well, some of the low-income countries, they were not ranked high at all. So basically, the way that we were assessing countries' preparedness was not brilliant. So this is something that for the future we need to think about, not just how well we monitor and we assess countries' preparedness, but what we are assessing. And I'll come to that. Then the second big lesson was that what happened initially here in China, and how China reported, and the very initial sort of response from WHO, that was actually not bad. Many people have been criticizing China, saying that China didn't disclose the information. Our finding was that, yes, some delays, but big picture, they were following the protocol. The big issue was then later on, months after the first cases, and WHO was not allowed, or the Director General was not allowed to declare this a pandemic or a public health emergency of international concern, because the advisory committee that he has at hand were not united. So he waited then another week before he said that this is a public health emergency of international concern, and the abbreviation for that is a FAKE. And the problem was then, this was the end of January 2020, the world did not understand what this meant. So very few countries reacted. So what we said from the panel was that the month of February was a lost month. 11th of March that year, the Director General said that this is a pandemic. And that was also the time when we in Europe saw that the hospitals were beginning to fill up. Then the world reacted, but then we lost another 6 weeks. And this was then 2.5 months after the first cases. So the alarm system actually formally worked quite well, but in terms of people understanding what this meant and what you needed to do, did not work so well. And that leads us then to what you asked about. We did then 28 country studies as part of the work of the panel. We didn't do sort of individual country reviews, and we didn't rank countries, but we rather tried to see what were the patterns, the 7 best countries and the 7 worst countries. And we saw that countries that had a previous experience of like SARS, what happened in 2002, and those were mainly countries in East Asia, like South Korea, Thailand, Singapore. They knew what to do, and they did that quickly. They didn't close down the countries, but they were aware about this could be something quite difficult and dangerous. So they would use what we call a surgical and aggressive containment strategy. Directly isolating, stopping. So they were really, and they were using a whole of government approach. They were mobilizing different parts of the government, well coordinated, used local communities to support the work at the local level. So there were some characteristics that we have in that paper saying this was what we saw at that time best practice. Then we had the other group of countries that basically denied, saying this is not an issue. We don't believe in this. They diminished the importance of this, saying that, yes, this is basically nothing. And also in some way inserted some distrust among people. Don't believe in this in terms of how they were sharing information. And then, of course, then you have countries like Brazil and the US being the worst cases in some way on that side. But then you had a big group of countries in the middle here, including my own country, Sweden, that basically took the approach that we have strong health systems. We will cope with this. We will manage. And I think that was also, looking back then retrospectively, a mistake, because they didn't react fast enough, early enough. And they waited and thought that, I mean, yes, we will pick this up. And that was very much all European countries saying that, yes, we have the capacity, but countries first didn't react well enough. You talked about human resources. They didn't have a plan to how to be able to manage them, quite a heavy burden on especially intensive care units in the hospitals, how to redeploy people, how to be able to maintain other services at the same time, how to be able to prioritize, how to be able to have people working around the clock for weeks after weeks. There were no plans in basically none of those countries. So they thought that the system was big, it was strong enough and resilient enough. And I think all countries today will say, no, we were not prepared well enough.
And as a side component of that, you know, per your paper on investing in community resilience and this theme of that this was our first digital pandemic, important learnings there.
Yeah, I think it's interesting just to make a parallel to what happened during the Ebola outbreak in Western Africa, where you have really strong community organizations. And they were extremely important here in terms of building trust with people, to be able then to communicate with people in terms of what behaviors actually need to change. You needed to wash your hands, but what was more difficult was basically the behaviors around how you took care of people who had died. And we worked especially with the local Red Cross societies in terms of how you will be able to still respect tradition and having a dignified burial, but a safe burial.
Right.
So they were extremely important to local communities here in terms of then ensuring that we got people with us. If we look at the COVID-19 pandemic and what happened, and what was mainly, and I would say most importantly, perhaps happening in high-income countries, you have very little of those communities today. In Sweden, we don't have any strong community systems. I mean, in the US, you have more of that, especially links to the churches.
Yeah.
So when you started in the US vaccination of people, the engagement with people through local religious church communities was extremely helpful at the beginning, really, to have a conversation with people that, yes, you should actually go for a vaccination. But otherwise, we don't have that kind of fabric today in many high-income countries, which is an issue, especially as this pandemic was a lot about people's anxiety.
Mm-hmm.
And the way that social media today were both helpful and not helpful, because what did people listen to? What could you trust? What to do, what not to do? I mean, social media this time put us in a totally different situation than what we have been any time before. And that created then, as I said, sometimes helpful possibilities to reach out to people, but it created a lot of anxiety. So coming back to your questions also about global health diplomacy and politics, a lot of political decisions were taken not on the basis of public health evidence, but in order to be able to meet and to respond to people's anxiety. Why did we close schools? Why did we close the borders? Was that because we had strong public health evidence that we should do that to stop the spread? No. It was mainly because of you as a politician. You needed to show people, now we are taking firm decisions and we are taking care of you. You will be safe. And because of that, certain actions were taken. That is at least my view on this. But we have very little also research around the non-medical public health measures that were taken. But the role here of what happened in communities, in between people, how people trusted each other or not, how they trusted institutions or not, how countries trusted each other. There's a lot here that I think for future pandemics, we need to learn from. And as I said, the way we assessed countries' readiness, preparedness, no one looked at this. So if we're going to look for the future now to see whether countries are ready or not, we need to factor in much more of, I mean, how are you going to cope with information flows in societies? How are you going to cope with people's anxiety here? How are you going to cope with that there is not trust in the public institutions? We need to find new ways of, both in terms of research to understand this, but also to be prepared how to deal with this. And we need then, when we make our assessment, to look whether countries have put this in place or not.
Mm-hmm. Mm-hmm. Anders, moving from communicable to non-communicable,
yes.
because you have been involved in a variety of initiatives on this front as well. And I thought, again, speaking from political side of things and the cultural angle, you were part of this STAX, sugar, tobacco, and alcohol taxes group. You wrote this paper in The Lancet back in 2018, again, comparing and contrasting, looking at things like, a sugar tax in Mexico, tobacco taxes in South Africa, alcohol taxes in Finland. And at the end of the day, we're spending, well, at least here in the United States, we spend trillions of dollars on these diseases directly related to these three. Talk a little bit about STAX, if you would, and a little bit about what you learned. And again, some of your experience in sort of moving the needle on this issue, a set of issues, which is quite culturally and politically connected.
Yeah, no, absolutely. I mean, I can start with just one very specific from Sweden. I mean, in Sweden, when you have people for dinner at the dinner table, you can speak about sex, you can speak about drinking, you can speak about smoking, but you can't speak about obesity. That's very much a taboo issue.
Interesting.
And I think this, I'm going to counter this. This is a core at it, that a lot of those issues has to do with values in society.
Yeah.
And values in society, cultures is also driving, and is also enabling politicians actually then to introduce a tax or not. A lot depends also on what is then feasible in society, and a lot of this is political. But taking a step back before going into that, this is my really passion today, is around the NCDs and the risk factors then triggering this pandemic in the world.
Yep.
And why this? This is also based from my own perspective. Just looking at epidemiology, what is really causing people either from dying, and especially premature death before this year of age of 70, but also then what is causing people to be sick while they are still alive. All data points in the direction this is, of course, what we need to address, and this is what is going to grow. So if we again go back a little bit historically, during that MDG agenda, when we were working on maternal mortality, child mortality, and the 3 diseases, when we began the sort of MDG work, there were 20 million people dying from the 3 diseases, maternal death and child mortality. Now that is down to 8 million. So we made some progress. We still have an unfinished agenda, but still, I wouldn't even call it a big success. Simultaneously now, we had seen an increased number of people dying, and then I used the number of how many people that are dying prematurely before the age of 70. We have now almost 17 or 18 million people dying prematurely from NCDs. So twice as many as the unfinished agenda from the MDGs. Twice as many. And then many people are thinking that the NCDs, cancers, strokes, coronary heart diseases, are diseases for rich people, are diseases only for high-income countries, and that are affecting people that basically can afford a good life. That is not true, not true at all. Out of those 17 million people dying prematurely in the world today, 85% are dying in low and middle-income countries. A couple of years ago, the most rapid spread of NCDs or escalation of NCD premature mortality was in Tanzania. If you look at who are most affected, both by premature death, but also with the risk factors in your country, in the US, but also in my country here, are the lower socioeconomic groups. So those are, the NCDs are really also diseases and risk, people affected by those risk factors, poverty related 100%, more or less. So this is the background why I think it's important to focus now on the escalation of NCDs. We need to die from something, which is, I would actually say, even something good. But what we should focus on is this premature mortality. Because people dying before the age of 70, both you lose people that can continue to live good and healthy lives, you're losing people that are productive and can contribute to the economies. But then, of course, if you look not just in terms of premature mortality, but also people being affected by diseases and living with diseases, that costs a lot of money then for the healthcare systems in countries. Then there are, in some way, different strategies here. Either you will just wait until people fall sick, and you will have an increased burden on the healthcare system to take care of people living with diabetes or cancers, etc. Or you are doing that. Yes, you need to still invest in good access to healthcare for people, but you're also focusing then on the prevention. And again, this is where the taxes comes in, because if you look at the major risk factors from them being affected by some of those non-communicable diseases, it's smoking, it's alcohol, it's lack of physical activities, and it is food-related risks. Those are the big risks. Plus a bit also the social fabrics, that people that do not have enough of social networks, they are also more at risk. So 1/3 of cancers today can be prevented. Smoking, yes. Staying in the sun, yes. But then the food and the physical activities are quite important. And a key passion from my side is the food agenda, because that is the most difficult one. if you look at, and you're coming back to the stacks and the taxes, if you look across the world, what we have achieved in terms of smoking, we have done quite well. We're not done yet at all. Still more work needs to be done. But if you look at what has happened now in terms of having less people smoking, having smoke-free environments, having a culture today, when you go to a meeting, no one will today accept that you're in a meeting room and people are smoking. 20 years ago, that was totally acceptable. When I started working at Swedish SIDA in 1992, now 30 years ago, people were smoking in their rooms. When I worked at WHO, and then when I became the acting director general, we were negotiating then with the UN Palais, the main building in Geneva for big meetings with the United Nations, where the World Health Assembly just have started yesterday. We said we would like to have a smoke-free environment here. And the head of the UN building then, the Deputy Secretary General, he said, no, I can't refuse my staff not to be able to smoke when they go to the restaurant. This was in 2005. Today, of course, this is unheard of. It's a totally non-smoke environment. And when we also at the WHO at that time said, we're not even going to hire people that smoke. People were outrageous, said, you can't do this. This is a human right to smoke. And we said, no, we think you got that wrong. It's not a human right to smoke. As a company or an organization, we can decide on what policies we will have in place. And we did that. And that's still in place for WHO. Then, of course, we supported people that wanted to quit smoking, and we didn't throw them out if they were already employed. But as a policy and a signal, this was extremely important. So I think if you look at the mix here on smoking, a mix of both policies, knowledge among people, but also then having the tax as an instrument here to make it more difficult for people then basically to smoke by increasing the prices. Big picture, this has, I think, been quite successful. But as part of that equation, as I was saying, has been not just the tax, not just the policy for non-smoking environment, but it has been the value among people. I mean, among peers today, you see the people that are, I would say, having more higher education, are better off, higher socioeconomic groups. In those groups, you see that the acceptance to smoke is less. If you say lower socioeconomic groups and certain groups of cultures, you have more of acceptance. So this factor to see how you can work with different instruments. And so that's why I think the tax on sugar is much more difficult. And it's proven to be much more difficult for those reasons. That we have less of a case to say that eating sugar is totally dangerous, like we have with smoking. Smoking is just a no-go. You should not smoke, end of the story. We can't say that for sugar. We know that consuming too much sugar is not good for your health. But we can't say that sugar should just disappear. I mean, some of us might think that would be a good idea because we don't need sugar, but still, you can't really make that argument. Culturally, to say that people should not be allowed to eat candies, chocolate, ice cream, difficult. And as I said initially, also culturally here, at least in my culture, to talk about that there is an issue that, hey, my friend here across the table, I think you have a few too many kilos. I think you shouldn't have some extra dessert. You should avoid sugar. Extremely sensitive, very difficult. So the different taxes that you can use for tobacco, on alcohol, those are easier. And I think more straightforward. And you can also see in many countries that there is a direct impact on the consumption. On the sugar tax, more difficult, but I strongly believe that we need to do more work on this. But you have to understand in some way both the culture but also the political context for this. It's much more difficult. And it's also much bigger powers here when it comes to the food industry and how the food industry is also working against us here.
While we're on this topic, I wanted to, if we could loop back about 5 years prior to this. In 2014, I noticed that, Anders, you were on a panel at the Uppsala Health Summit. It was focused on healthcare for healthy aging. And, we just talked, you talked eloquently about sort of the premature deaths and these issues leading to NCDs. We have this other theme that's sort of been building up, and it's been kind of a hot topic for us lately, but this principle of health span, that we do have these very large populations that are living quite long, but there's an imbalance between lifespan and health span. Love to just get your perspective on sort of where we are, because there's been one of the themes that we've seen a lot on the show is this concept of, hey, if we could create a system that targets biology of aging as opposed to, the cancer or the Alzheimer's or the diabetes type 2 directly, there may be a lot of savings there, let's say, once again, looking at those trillions that we're spending at that point of life. Take us into the world of healthy aging from your work, maybe from a Swedish perspective. Take us down that road.
Yeah, I suppose I'm getting there myself now.
Me too.
Into the healthy aging. No, I mean, it's a very important and very important question. Both if you look at the demography across the world today, what has already happened in Japan, the projection, what is going to happen in China, the biggest country in terms of, no, it's not the biggest any longer, it's India. But really what is happening demographically, this is so important to have an understanding in terms of how can we then ensure that people do not just live long, but also maximizing the healthy life years you're getting. This whole concept that you're not just focusing on surviving, but also to see that how can you maximize that you are actually living functionally healthy. So you can live with a chronic disease. I'm living with 2 chronic diseases myself, but I'm very healthy, totally functionally healthy. So how can you maximize either that you don't fall sick or that you can continue to be healthy and productive? And why is this important? It's important for 3 reasons. First, of course, for yourself, it's quite nice to feel healthy. Sure. Second, it's good for the healthcare system and the costs and the burden of the healthcare system. But it's also important for the productivity and the economies of countries that you can have people that are actually continuing working. So there are strong arguments to focus not just on people surviving, but making sure that you maximize what we call healthy life expectancy. And this is one of the things I'm very proud of, that the present SDG, part of the Agenda 2030 SDG 3, there was a big political sort of, I wouldn't call it fight, but then process at least, around what should be the future global health goal. We had the MDG goals. We had 3 goals out of the 8 focusing on health. Now there was going to be a different set of goals. We had a process then leading up. We did what we call the thematic consultation to see what should be the future goal here. And Botswana and Sweden were leading this, and we had a big meeting in Botswana in 2013. And there was basically 2 options. Either we should have a goal that was universal health coverage. And this was the priority of Margaret Chan and WHO, Japan and France of that time. Prime Minister Abe from Japan was very keen on this, and France as well. Then we were another group of people, myself, that at that time the head of UNDP, Helen Clark, and some other people that saw that universal health coverage was an important means, but not an end goal. And we were arguing that the end goal now, we need to move from just focusing on survival to also healthy lives. So the present SDG is actually maximizing healthy life expectancy. And that was an outcome of that Botswana meeting. So I actually wrote the report and formulated that goal. I don't think people yet have realized that that is the goal, to be very honest and a bit provocative. Understanding that this is really now what we need to strive towards. And if we're going to do this, we need to have a totally different approach and agenda. So it's no longer enough to focus on the health sector. The health sector, their research saying that what comes from the health sector is only 11% of what is actually contributing to people's health. The rest is coming from other sectors and also a little bit biology and genetics.
Cool.
So if we really are going, and then we're coming back to those risk factors, if we're really going to deal with this burden of NCDs and premature mortality, and not just mortality, but also ensuring more healthy life years, we need to look much more in terms of how do we get the help from what people are doing on food, healthy food, good and effective food systems, energy, urban planning, physical activities, infrastructures, playgrounds for children. These are factors that are much more important for people's health. And this is exactly what Agenda 2030 is about. It's not a set of goals in silos, in isolation. It's about how the interaction goes in between different goals here. And if we're going to be effective on one goal, we need also then to both get help from, again, what other goals are striving towards, but we need also to show what climate people are doing is actually extremely important for people's health, and we can be quite helpful to the climate people. So focusing on healthy life years and healthy life expectancy, this is now in the WHO strategy, what is called the General Program of Work. So the WHO is building their strategy on 3 pillars, but the overarching goal there to be measured is actually healthy life expectancy. It's still not done. I don't think people again see the beauty and the strategic importance of doing this, but I hope that we will get there. Because when we begin really to focus on ensuring that we create the opportunities and the conditions for people to be able to make more healthy choices when it comes to food, the physical environment, clean energy, also the mental well-being. But then we need to be thinking more in terms of the society where we live.
Right.
And how can you then at the local level, coming back to your community or working with your mayor in your city, how can you then see how you can create an environment that is really enabling people to make those choices? And it's about the knowledge, but it's about the resources to make it affordable or not affordable, as you were speaking about tobacco, but making it affordable actually to bike instead of actually taking the car. And then, again, what I've said, the culture here, the values in society, so that you create an environment where people appreciate having green areas, appreciating that children have the possibility to go out and to play in the playground instead of sitting with their iPhones, where children today spend most of their time, but having that kind of culture and values in societies. I think that is really what is most important, but of course, very difficult. It's a tall order, but I think that is where health and our global health work needs to move towards the future. And having that goal of maximizing healthy life expectancy helps us getting there. If people understand also what it will take, it's not enough with the vaccine.
Right.
You need to see how you create a society that is enabling people to make more healthy choices.
Yeah, I think you're spot on. I love the way you speak so eloquently about this. But again, making these connections, as you were saying, to the social determinants, to unrelated, tangential fields, energy, the environment, intergenerationality.
It's very difficult. When I speak to my climate colleagues or food colleagues or urban planning city colleagues, they think that I'm coming there as a global health ambassador. Okay, you want me to do health? No, we are doing climate. And I said, no, I don't want to do health, but I would like to offer you just to show that what you are doing will have huge impact on people's health. The mayor in Paris now, making Paris green, now making it possible to bike in Paris, and the cars only allowed to drive 35 kilometers, making Paris much more good for climate and greener. Is he using the health argument and saying what impact this will have on people's health? No. So this is really one of my top priority work with colleagues to see How can we in some way just enable our mayors, our climate colleagues, our food colleagues, our energy colleagues with the data and the analytical tools, how they can actually use the health argument also just to pursue and to continue and to push their agendas. But it's difficult.
Oh, yeah, yeah. Well, I'm glad you're thinking about it, though. So, Anders, what else is coming? I mean, you mentioned the new role coming up, I guess, later on this year. But any other major initiatives that you're going to be embarking upon per 2023? Obviously, universal healthcare is sort of underpins, a lot of what you've been writing about lately. But anything else that you want to mention while we have you with us today in terms of either the existing ambassador role or the new initiatives?
I mean, my two priorities for the fall of the coming years will be around what we have been speaking about, the work around what we call healthy societies and maximizing healthy life expectancy, and to see how we can engage more with the non-health sectors. So that's one important piece of work. I'm working with the UN University and the International Institute for Health in Malaysia to see whether we can build something here. And the other one is around global health diplomacy and having more of understanding of the importance of political economy, help people getting more training in that, and diplomats and politicians sort of having a little bit more understanding of health and how health can be useful as an entry point also for other negotiations. So, I mean, for me, those are the two big ones. Then, of course, there is continued work now, what came out now, or what is still on the table from the COVID-19 pandemic, to see how we can create a safer, more safe world for the future. So the high-level meeting in the United Nations in September, it will be on universal health coverage and on tuberculosis. But for me, the most important one is on pandemic preparedness and response, and to see whether they can, or we can persuade our politicians to take some firm political decision to say, yes, we need a new global rule system here with a new pandemic treaty. We need more financial resources. We need a more independent and high quality WHO. We need a better platform for having access to vaccine in the future. And we need some sort of political platform where we can have the possibility to basically to problem solve and to not have the kind of same political tension as we had this time. So there is now work still to be done on seeing the lessons from the past and the work we did with the panel to see whether we can translate that into political decisions now in September. But the political environment right now is difficult, but we are still working on it, of course.
Well, we for one, as a platform, are rooting you on. I mean, an amazing journey, Anders. I really appreciate you sharing it with us, and just going to continue to follow everything that you're doing to make this vision of healthy societies reality, because it's just it's so real and pertinent as we're in this 2023 environment. And again, as I said, wishing you the best with it. Again, for everybody that is going to be listening to this particular episode of our show across the various podcast networks or watching on our YouTube channel, again, you've been spending time with Dr. Anders Nordström, Ambassador for Global Health, Ministry of Foreign Affairs of Sweden, Secretary of the Independent Panel for Pandemic Preparedness and Response to WHO, and member of the Virchow Foundation Global Health Council. Again, Anders, thank you for taking so much time out of your schedule to come talk to us. Thank you for what you're doing. And as we like to say here on our show, thanks for creating a better tomorrow for all of us via what you do.
No, thank you. It was a true pleasure. Thank you.